Assalamu alaikum. Thank you so much for coming today. Thank you for the host and thank you for the invitation. I'm going to talk today about the vaccinations in rheumatic disease, going through some principles and rules. Now, my slides will be inspired by the Euler Society and the Swedish guideline for vaccination in the rheumatology. So we're going to go through the principles and recommendations. First principle of any vaccination following the ABC of medicine is a relevant vaccination status and history, and indication for new vaccination should updated by attending physician. So it's important that the attending physician or the rheumatologist should know about the previous history of vaccination, side effects, any allergy for any food that can be associated also with vaccine allergy. A study from Denmark provided information and recommendation on vaccination from healthcare professionals among patients with RA, better vaccination coverage for influenza. So a usual reason why patients were not vaccinated was they didn't receive relevant information. So we have to think also from a patient perspective to explain for him, and we really spend some time to explain why are we going to take this vaccine. So information is very important. Now, this is a list of the vaccination, the common vaccines that we use: the Haemophilus influenza, hepatitis A, B, herpes zoster, again with the vaccine on the other side, influenza, meningitis, rubella, streptococcus pneumonia, tick-borne encephalitis, and tetanus toxoid. Number two, each patient should have an individual vaccine program designed in a consultation between patient and attending physician, whether rheumatologist or internal medicine or primary healthcare doctor. Should be done in collaboration between patients. Okay, thank you. This should be done in collaboration between patients, attending physician, and maybe other facility. Now, this is a challenge that we face in our daily work, that there is no much time. You have barely time to evaluate your patients, give a diagnosis, give a treatment. Now you have to also take care of the vaccination. So a good communication with other facilities can help us a lot to achieve an optimal treatment plan. Such as this large survey among RA patients in UK demonstrated a good vaccination coverage linked to close collaboration with primary care for the implementation of vaccination programs. So you are not alone in this system. Yes, we have the same patient, but we can have some help from other centers that can help us. We take care of the medication, another facility take care of the vaccination. Maybe the patient cannot make it to come every time to the hospital that is far away from him, but they have a close primary healthcare center where they can afford the vaccination. So a good collaboration between healthcare units can help us to achieve an optimal vaccination program. Third principle is patient with rheumatic disease should ideally be vaccinated when disease is stable. Good question, when to give the vaccine? Yes, when the disease is stable. The thing is, there is no studies that compare the effectiveness and problems, side effects of vaccinating rheumatic disease patients with stable and unstable disease. Unfortunately, we don't have such a study. But the majority of vaccination studies are done on patients in a stable disease phase. So there's a study from Brazil demonstrated reduced antibodies response after influenza vaccine in patients with juvenile SLE and high disease activity. Other studies that include rheumatic disease patients with moderate and high disease activity showed no increased frequency of side effects or relapse, no worse effect compared to healthy controls. Now, this is something that I want to illustrate. You're going to notice that there is a wide gray area in rheumatology. It's not always black and white. The gray area is a little bit wide. When it comes to that, we choose to select the safe area. Don't risk it. As the same as I'm showing, like studies that gives opposite result. One is saying no problem, the other study is saying there's a problem. So we tend to be careful in rheumatology. So the recommendation to preferably vaccinate rheumatic disease patient in stable phase is therefore based on expert opinion. That's what I'm trying to say, as there are theoretical possibilities that the vaccine can trigger a relapse. Fourth principle, if possible, vaccination should ideally be carried out before the planned start of immunomodulators treatment, especially before planned treatment with rituximab, CD20 inhibitor. The general discontinuation of immunomodulatory therapy already in progress is not recommended. So this is like one of the main things. When you see a patient, one of the plans, we try to start medication, but earlier to that, we try to give the vaccine. Now, several studies has reported that rituximab, aka Mabtera, reduce the antibody response after vaccination against influenza and pneumococcus. This is actually the only one that we need to be a little bit careful when giving the vaccine. The thing is that we are not worried about side effect of the vaccine with the medication. The thing is that we are worried that we don't get enough protection from the vaccine because of our medication. This is the main concern. Vaccination against mainly pneumococci is therefore recommended, if possible, about 4 weeks before the start of treatment, which is not usually possible because we have a patient with a flare-up and we have to do something and then vaccination will come later. Or maybe 6 months after the last infusion. So until the effect of medication ceases from the body, then we can give the vaccine so that we expect the body to produce antibodies. Timing of seasonal flu is also difficult to adapt because when it comes, so it's just to take it. And then there's currently no support for customization or stopping immune modulatory therapy before vaccination. This is done by the assessment of the EULAR group. To continue, abatacept, which is working on T cells mainly, has been shown to reduce the antibodies response for influenza vaccine. Other study, prospective study, antibodies level were found of influenza and pneumococcal vaccine with abatacept. They found it, so there was no problem with that. This is what I mean, like you find like studies that shows there's okay and it's not okay. RA spondylitis treated with TNF inhibitors, a study showed reduced antibodies after influenza and pneumococcal vaccinations. But however, there's another meta-analysis treatment with TNF inhibitors was not associated with impaired response. So again, controversy. Studies that shows yes, studies that shows no. Tocilizumab, IL-6 inhibitor, aka Actemra or Actemra, seems to be no effect on the vaccination on studies. I couldn't find a study that shows that it affects the titer. I think here is the tofacitinib, the same thing. It's a JAK inhibitor. We have also 2 studies that shows whether it helps or not. I believe I'm gonna, yes, steroids, especially in high doses, 20 milligram and above, seems to have an effect on the effect of the titer of the antibodies of the vaccines. Again, we have some group of medications, azathioprine, mycophenolate, mofetil, Celcept, and cyclophosphamide in 2 studies. One study shows it affects, and another study it doesn't affect. Our beloved methotrexate seems to have some studies that also affect, but still the improved antibody response on methotrexate withdrawal is marginal, and holding of methotrexate with seasonal influenza vaccine not recommended. So in summary, our beloved methotrexate is assessed that sufficiently good immune protection is achieved during ongoing methotrexate, so we do not hold it. So, in summary, collected data from several studies in recent years have provided support for vaccination against influenza, pneumococci, hepatitis A and B, tetanus, Haemophilus influenza B among patients with rheumatic disease under ongoing immunomodulated treatment with systemic steroid. And in most studies, patients with rheumatic disease achieve enough good immune protection. No serious safety signals has been reported in a relatively limited follow-up time. 5, live attenuated vaccine, which is a common question that we get. These should be avoided as much as we can to immune-suppressed patient in rheumatic disease. Now we have live attenuated vaccine that contains live viruses, bacteria. These can potentially give rise to serious infection in immune-suppressed patients, our patients with medication. However, it's unclear which level of immune suppression increase the risk of such a vaccine infection, but this is something that we avoid. So until then, and pending further studies, we advise against all guidelines patients who are treated with immune suppressive drugs to vaccinate with live attenuated vaccine. There's no place there. One exception is a revaccination booster dose, usually relevant for children with the living weakened measles, mumps, rubella vaccine, MMR, the booster dose. Otherwise, and this should be carefully evaluated. A live attenuated vaccine can be given, now sometimes we need to do a good evaluation. It can be given 1 month before the start of the planned treatment if we didn't start yet. About vaccination with live vaccine during ongoing immune suppression treatment, is necessary treatment interruption is recommended, so we have to stop it, not like the previous one. And then there's lack of scientific studies how long treatment break need to be probably done. But in general, with DMARD, we can reintroduce our medication 1 month after vaccination with the live attenuated vaccine. Careful with that, should be like have a good discussion before we decide it. These are the list of the live vaccine. So in summary, have been given to patient. The studies didn't show major report security issues. However, these studies have different type of limitation, mainly small size. Usually those studies were small, we cannot generalize. So the overall assessment is non-sufficient support for recommendation for the live vaccine. These are the studies, I will not go through them. So recommendations, what are the vaccines that we usually recommend? We have mainly 3 vaccines, 2 vaccines and a new vaccine that we're gonna focus on, and then the rest we can go through them rapidly. So the first one, the seasonal flu. The annual vaccine against seasonal flu should be strongly considered in patients with rheumatic disease. So vaccination against seasonal influenza should be done with the usual vaccination group, regardless for the ongoing rheumatic therapy. Normally, it takes about 2 weeks before you get good protection from the vaccine, and the effect lasts about 6 to 9 months. There is some support that a booster dose influenza vaccine in patients with rheumatic disease can provide a better antibody response. WHO and Public Health Agency clarified before each flu season if 2 doses should be. This like we usually get these recommendations. Okay, so these are the studies that shows the effect of the vaccination, how it can decrease in our patients, the effect. So second vaccine is the pneumococcal vaccine. This is strongly should be considered in patients with rheumatic disease, to patients with the highest risk of severe pneumococcal infections, patients with several risk factors, patients and with reduced immune system due to illness or treatment, which after an individual assessment is considered to have a very high risk for severe pneumococcal disease, which usually all our patients. So this is a group of the very high risk. As we can see, the S-splenic splenectomized, CSF leak after trauma, and then the immune compromised. Here we have our group in the reduced immune system due to disease or treatment. In our case, it's treatment mainly. Cochlear implants, cystic fibrosis, organ transplantation also could be a cause. Now, before we had a very high, now we have increased risk of pneumococcal. This is the groups that can have it also. In our patients, I give an example, suggestion for patients group with inflammatory disease and very high risk. For example, treatment with rituximab, cyclophosphamide, and long-term prednisolone, regardless of the rheumatic condition. Treatment with DMARD and an additional risk factor, such as age, heart failure, or lung disease, is making it very high risk. Treatment with DMARD with a systemic organ involvement is a very high risk. And then patients who are judged to have a very high risk for serious pneumococcal infection as a result of impaired immune system after individual assessment by doctor. This is very rare, but we tend to face it also. These are the studies also that shows the evidence for how important it is to do the pneumococcal vaccine. Now, as we said, only the one that we should be careful is the rituximab. This is a study here where showed the antibody response after vaccination after 16 to 24 weeks. Adequate antibodies, 87, 97%, respectively biologics and conventional synthetic DMARDs, while significantly reduced response with patients with rituximab. Again, the only medication that we usually try to avoid vaccinate is the rituximab. So, third one is the new one, the herpes zoster. I don't know if you noticed recently on this Shahid application, they have this about the shingles vaccine. No one is watching Shahid application here, right? No series, no nothing? No, okay. So anyway, they are promoting very recently about it. So the non-live vaccine is called shingles, is available. Now the other one, the old one, is the live attenuated, the Zostavax. This one is not recommended. Now, we have noticed that there is an increase in the herpes zoster infection after our medication, especially with a specific medication called JAK inhibitor, the tufacetinib and the other JAK inhibitors. We highly recommend to have this vaccination. Now, according to guidelines, above 50 years old, we should be vaccinated against it. Under 50 years old, with a rheumatic disease and a medication that we use, yes, we should also give this vaccine. So these were the main three vaccinations that we use. Now we move to the other recommendations. The tetanus, a tetanus toxoid, we should be also vaccinated, same as all the population. Human papillomavirus, this is a vaccine that should be carried out in a specific location. It's not really easy to discuss this vaccine, but also mentioned in the recommendation, mainly in Europe. Hepatitis A and B also should be considered as a vaccination, but usually we have them vaccinated before we see them. So nothing of these three which we do routinely. Now, patients with rheumatic disease also who plan to travel, they have also to get any vaccine which is recommended. This is also something we need to discuss with our patients if they are intent to travel. Now, the family of the patients with a good immunity, we should also encourage them to have the vaccine according to the national guidelines. Now, this is like the optimal vaccination protection for the patient that we can provide for the patient himself and the surroundings. If we achieve that, then we have an ideal, optimal program of vaccination and a perfect protection for our patients. Vaccination against TBE, tick-borne encephalitis, is also considered in places with the endemic area of TBE. That was the last one. So in general, three vaccinations that we usually deal with: flu vaccine, seasonal flu, pneumococcus vaccine, and the herpes zoster vaccine. Now, good news for UAE, we have our colleague, Dr. Ahlam. She is carrying out, leading a team who is doing like the recommendations. It will be our guidelines for vaccination. Inshallah, it will be published soon, I believe in a couple of months. We have a meeting on June to discuss this final. And then inshallah it will be published so that we will have our own guidelines for vaccination in rheumatology, inspired also by the URAL guidelines. These are my references, and thank you so much.